Hello, everyone. Thank you for joining me on this program on interstitial lung abnormalities. My name is Joe Mamaropoulos. I'm a faculty member in the cardiothoracic division at the Duke Medical Center. This presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals Incorporated. The company has provided financial support for this program. Presentation content has been reviewed for consistency with FDA guidelines. Let's begin our discussion of interstitial lung abnormality by introducing you to the term of interstitial lung abnormality. So what is interstitial lung abnormality? What is ILA? Well, ILA is thought to represent early or subclinical forms of pulmonary fibrosis. These forms are seen on cross-sectional imaging or on CT. Oftentimes, these earliest forms of fibrotic lung disease can look like senescent change, so normal aging of the lungs. If you are reading a thoracic CT, what are the imaging findings that are going to help you to identify if this patient may have interstitial lung abnormality? Well, here are some specific clues that can help you identify interstitial lung abnormalities on CT. One, you should be looking for ground glass opacities. You can also look for reticulation. Lung distortion also happens in patients with interstitial lung abnormality. Traction bronchiectasis or bronchialectasis that we see in normal fibrotic lung disease is also visualized with interstitial lung abnormalities. Honeycombing, although I think of it as an ILD or an interstitial lung disease term, can also be seen with ILA and non-emphysematous cysts. I will be showing you imaging findings for most of these described CT findings that I just described, and I'll show you those towards the end of the talk. Importantly, if you're defining or identifying a person as having interstitial lung abnormality, we want to make sure that at least 5% of any lung zone that you are viewing on a chest CT is involved. And really importantly, interstitial lung disease should not be expected in this patient. So this is the patient who just had an incidental CT scan, a cardiac CT potentially a PE scan, and all of a sudden you're seeing some of these imaging findings that we just described. This is when I want to be using the term interstitial lung abnormality. So as we just briefly introduced to you, ILA is a CT finding. So it is a finding that's going to be seen on chest CT when you are viewing thoracic images. So where did we identify ILA? Well, ILA, the term really emerged because of a large cohort analysis of multiple different studies, including COPD gene, pulmonics, and importantly, lung cancer screening. Many of these studies demonstrated that the prevalence of ILA was anywhere between 4 to 9% among smokers and 2 to 7% among non-smokers. What are the clinical findings associated with ILA? Well, often these patients who we have identified with interstitial lung abnormality will have chronic cough, shortness of breath, reduced exercise capacity, and decreased total lung capacity. So what are the risk factors for interstitial lung abnormality? Well, all of these large cohort clinical studies demonstrated that tobacco exposure and different inhalation exposures are independent risk factors for the development of ILA. In addition, we know that increasing age is a risk factor for ILA as well. The genetic epidemiology of COPD study demonstrated the prevalence of ILA had increased from 4% in patients less than 60 years old to 6% in patients greater than 70 years old. Another very impactful study for interstitial lung abnormality came out of the Framingham Heart Study, which demonstrated the prevalence of ILA was 47% in patients greater than 70 years old. Now, when we talk about interstitial lung abnormalities, one of the major CT findings that we see is basilar reticulation. But be aware that reticular abnormalities in older individuals may be present as part of senescent lungs. So we think some of this reticulation may be part of the normal aging process of the lung, and it's important to try to separate out interstitial lung abnormality from these patients with senescent change. In addition, we know that ILA is associated with other biomarkers of aging. However, there is an independent increased mortality risk for having interstitial lung abnormality. So we briefly talked about some of the CT findings that can be seen with interstitial lung abnormalities. Well, now let's actually show you the CT findings that we see with ILA. So the first CT finding that we talked about with ILA is the presence of ground glass. So what exactly are we talking about when we describe ground glass opacities? Well, ground glass opacities are just nicely shown here in this examination. This is a cross-sectional examination of the lung bases where we see ground glass opacity in both the left lower lobe and the right lower lobe. Remember, to define ground glass opacity, this is an airspace opacity that occurs in the pulmonary parenchyma that doesn't obscure the underlying airways and vasculature. So we see the opacity here in both the right lower lobe and the left lower lobe. However, we can see the vasculature through this airspace opacity. Another CT finding of interstitial lung abnormality is reticulation. This, for me, is probably the most important finding of interstitial lung abnormality. So when we describe reticulation, it's nicely shown here in this slide here. If you look at the left image, you can see multiple reticular opacities. Again, these are these small little areas of septal thickening that occur in the subpleural region of the lung that you can see oriented roughly 90 degrees to the pleural surface. You see them here at the right lung base and the left lung base, a great look for reticulation. What's happening pathologically? Well, what's really happening is in this cartoon image, these areas of the interlateral septa become thickened and give us this appearance of reticulation that we see on cross-sectional imaging. Another important finding with interstitial lung abnormality is lung distortion. This is not a term that I often use in my CT reports, but what we're talking about here is essentially when you begin to develop fibrotic lung disease, there tends to be volume loss. Sometimes that volume loss can be directed to the medial aspects of the lower lobes, is where we particularly see this. You have this architectural distortion that's indicated by the arrow here, and you get the sense that some of the lung is kind of being pulled towards the medial aspect of the lung. A great finding of interstitial lung abnormality is traction bronchiectasis. Occasionally, you'll see patients that have traction bronchiectasis towards their lung bases, but not really any lung findings. The image shown here in the right lung shows you a great look for traction bronchiectasis, where you have definite fibrosis in this patient that we're showing here that's basically distorting and tractioning and pulling those bronchi apart out to the periphery of the lung. In your patients with ILA, with interstitial lung abnormalities, you may see the most subtle findings of traction bronchiectasis or bronchiectasis and wonder what you're actually looking at. Well, this is a great time to deploy the term interstitial lung abnormality. If you see a bronchus that's larger than the local vessel, you can ponder, is this traction bronchiectasis or bronchiectasis, and use in your report the findings of this could represent interstitial lung abnormality because you are seeing basilar traction bronchiectasis or bronchiectasis. Another CT finding for interstitial lung abnormality is non-emphysematous cysts. So as we've seen with our patients with definite fibrotic lung disease, occasionally where they have these architectural distortions, this reticulation, traction bronchiectasis, you'll see these areas of just cystic change. We nicely show it here in the right lower lobe. This patient definitely has pulmonary fibrosis, evidenced by basilar traction bronchiectasis. There's some reticulation as well. But isolated here in the right lower lobe, we see this cystic structure. Occasionally, our patients with fibrotic lung disease, often those patients have LIP or potentially NSIP, will develop these cysts. So if I see non-emphysematous cysts, that could certainly suggest this person may have interstitial lung abnormality as well. One thing to consider when you are reporting ILA on cross-sectional imaging is to place ILA into different subcategories. So some of the subcategories are listed here. The first one being the non-subpleural category, and this would be interstitial lung abnormality without predominant subpleural localization. A second subcategory is subpleural and non-fibrotic. This is interstitial lung abnormality with a predominant subpleural localization and without evidence of pulmonary fibrosis. The last category of ILA is subpleural fibrotic. This is ILA with a predominant subpleural localization and evidence of pulmonary fibrosis by CT. The distribution of ILA in this first category is shown here, and this is the subpleural location. If we look at this patient's chest CT, what we can see is there are definite bilateral lower lobe subpleural abnormalities indicated by the arrows. You can see reticulation. You'd wonder if there's some traction bronchiectasis here. This is a great look for describing a subpleural location of ILA. When we talk about interstitial lung abnormality occurring in the central aspects of the lung, that is shown here with this image. If we look at the central portions of both upper lobes, here you can see left greater than right ground glass opacity. And again, ground glass opacity is going to be those opacities that do not obscure the underlying airways and vasculature. I can see the airways and vasculature through this. I've got central ground glass here. If I was going to describe this patient as having interstitial lung abnormality, this would be in a central process, not in the subpleural aspect of the lung. Next, for our distribution of ILA, this is the upper lung findings of ILA. Anytime you see ILA, you want to describe, is it upper, is it mid, is it lower? In this situation, we have upper lung findings where we see areas of reticulation, also with some traction bronchiectasis as well. A great look for upper lung findings of ILA, as opposed to this case where we have a basilar process occurring. In this situation, you can see in coronal imaging, this patient has definite basilar predominance of traction bronchiectasis with reticulation. You'd wonder if there's some non-emphysematous cysts going on there at the right lung base or potentially honeycombing. Another category of ILA is the non-subpleural and non-fibrotic ILA. That's demonstrated here. And you can see bilateral left greater than right pulmonary opacities. If you look there in the left upper lobe, it looks like ill-defined ground glass there in the left upper lobe. If we look in the left lower lobe, some ground glass as well, and also in the right upper lobe. All of these findings are in a non-subpleural distribution, so they do not occur on the pleural surfaces. Also, this is non-fibrotic ILA. I've got random bilateral pulmonary opacities. Certainly doesn't look like reticulation, traction bronchiectasis, or honeycombing. None of the findings we would use to describe fibrotic ILA. The next subcategory of ILA is the subpleural and non-fibrotic ILA that you nicely see described here or shown here with this CT image. If you look in both lower lobes, we do have subpleural opacities. So subpleural bilateral posterior pulmonary opacities, they appear to be consolidative. Whenever I describe consolidation, I'm talking about airspace opacity. That's going to obscure the underlying vasculature and airways. As you see here, both bilateral lower lobe posterior consolidative pulmonary opacities, subpleural in distribution, however, no reticulation, no traction bronchiectasis, certainly no honeycombing. This is non-fibrotic ILA. The last subcategory of ILA is the subpleural fibrotic ILA. This is the ILA when I'm reading a chest CT that I want to identify because this finding could go on to progress as interstitial lung disease. In this patient, what we see here at the lung bases, we nicely see reticulation, which is emphasized by the arrows. In addition to reticulation, we see what looks like the earliest forms of traction bronchiectasis and or bronchiectasis. This is where I want to be incorporating the term, this patient may have underlying interstitial lung abnormality. So anytime we are describing interstitial lung abnormality, it's important to know that there can be some mimics, and it's important to identify those mimics so we're not randomly using the term ILA. So findings not considered ILA. The biggest one for me is focal paraspinal fibrosis. We also don't want to talk about interstitial edema when we're talking about ILA or aspiration. This is a great image here that you see in a classic location, medial aspect of the right lower lobe for focal paraspinal fibrosis. As you see here, there is some subpleural reticulation, also some ground glass opacity. You'd also wonder if there's some traction bronchiectasis. If I look at the entirety of the left lower lobe and right lower lobe, I see that none of these findings are present. Only in this focal area And that's due to the fact that there is a large osteophyte there in the thoracic spine that's giving this subpleural reaction. This is a great look for focal paraspinal fibrosis. Additionally, some of our patients are going to be in and out of edema. If I'm in the acute setting and I see a lot of reticulation, I certainly want to be careful to not call interstitial lung abnormality until I have a baseline chest CT that's going to demonstrate that these findings are actually due to pulmonary edema. Findings of multifocal aspiration we see all the time. Those are often due to multifocal areas of tree and bud opacities that we'll often see in the lower lobes. Of course, we don't want to call these findings ILA. So I do want to emphasize that prone imaging is very important when we're talking about interstitial lung abnormality. Why is it important? If you have a patient that's getting a first-time chest CT and we see dependent opacities in the lung, sometimes these dependent opacities can be due to atelectasis. If you take a look at this image here in the left lower lobe, you can see that there are some subpleural opacities there at the left lung base. We also see them to a lesser degree at the right lung base as well. Now, this patient was performed at our medical center, had prone imaging performed because there was a question, does this actually represent interstitial lung abnormalities? And if you look at the prone imaging, you can see that these areas that we were concerned about that could have represented interstitial lung abnormality have completely resolved. And so for my initial baseline interstitial lung disease evaluation of a patient, I always get prone imaging because sometimes these opacities can absolutely represent atelectasis and completely resolve on prone imaging. Prone imaging, very important if you're going to call a person has ILA or potentially ILD. The imaging progression of ILA, it's very important. It's very difficult with cross-sectional chest CT to actually say, has a person progressed with interstitial lung abnormality or interstitial lung disease? However, we do see it. Multiple different studies have reported variable rates of ILA progression from 20% in 2 years to all the way up to 73% over 5 years. What are the findings that we see when we have progressive ILA or progressive ILD? Well, essentially, we see subpleural reticulation that will increase. Often these patients will have changes in their lower lobes with progressive traction bronchiectasis and potentially leading all the way to honeycombing. All of these findings are associated with progressive ILA. Kind of blur the lines between ILA and ILD when you have progressive findings, because if the findings of ILA have progressed, I'm starting to wonder if this patient has ILD. If we take a look at this specific patient in 2016, this would be a great time to call interstitial lung abnormalities. Look at these lungs, the left lung and the right lung, we see subpleural reticular opacities. That's really the only thing I see. Pretty nonspecific in 2016. But if I was dictating this report, I would say these findings could represent interstitial lung abnormality. If we look at this patient now at the same level, so I'm at the carina, in 2017, what has progressed? Well, particularly within the left upper lobe and lingula, you can see progressive reticular opacities. You even see it out in the right lung as well. But now, in addition, there's some traction bronchiectasis as well. I'm going to dictate this as now progressive interstitial lung abnormality. Consider interstitial lung disease in this patient. Now, if we look at this patient 2 years later in 2019, definite fibrotic lung disease in the left upper lobe and lingula, characterized most notably by traction bronchiectasis and bronchiectasis and progressive reticulation as well. So what are the clinical outcomes with interstitial lung abnormality? Well, we know that there's increased morbidity and mortality by just having ILA. What are some of these clinical outcomes? Well, these patients often have increased respiratory symptoms. So some of the findings that we see with our patients with pulmonary fibrosis, these patients with ILA have as well. They have chronic cough. They also have shortness of breath. By PFTs, these patients will have a decline in lung function, which is evidenced by reduced TLC and DLCO. Now, remember, a lot of our patients with interstitial lung abnormalities will be former smokers. So these patients have an increased incidence of lung cancer as well. We want to be screening these patients. So in our lung cancer screening group is when I typically deploy the term interstitial lung abnormality, because they're getting screened for lung cancer, but they also have findings of ILA as well. If you identify a patient with interstitial lung abnormality, be aware that they have increased morbidity if they have surgery. In addition, if that patient is getting radiation for lung cancer, I definitely want to report ILA because they have increased morbidity for radiation, as well as for all of our novel treatments with immunotherapy for lung cancer. These patients have increased morbidity as well. In addition, by deploying the term interstitial lung abnormality, these patients also have an increased mortality overall. So the biggest takeaway for this whole talk is, how should you manage ILA? What should we do as radiologists if you see findings of interstitial lung abnormality? I think the biggest thing is to actually report it. Don't just pass it by. This patient could be at the earliest stages of fibrotic lung disease, so it's important that we report the findings. In my reports, I will say these findings could represent interstitial lung abnormality. Often I'm seeing basilar subpleural reticulation with potentially traction bronchiectasis and bronchialectasis. At this point, this patient may have an incidental chest CT, never be seen by a pulmonologist. So the next thing that I'm going to dictate is this patient may benefit from a visit to a pulmonologist where PFTs can look for restriction. That may be the earliest time point that you are seeing restrictive lung disease. I would argue we're in the earliest point of reporting ILA. So maybe we're seeing it on the CT side before the pulmonologist is seeing on PFTs. So that's why it's really important that we're identifying these patients and potentially following up with these patients. I have these discussions with my pulmonologist. What should we do after you evaluate a patient with ILA? This is all an emerging field. Some of us say we should get follow-up chest CT in 6 to 12 months. The pulmonologist may want to get follow-up PFTs. I think this is emerging, and stay tuned for more recommendations on how to follow up these patients. Okay, now let's conclude this talk on interstitial lung abnormality. So remember, when you're reporting interstitial lung abnormality, know that ILA often represents the earliest form of fibrotic lung disease. These imaging findings are essential whenever you're describing the findings that may give a patient ILA. So I'm looking for the findings of basilar reticulation with traction bronchiectasis. We're determining if follow-ups are necessary, but I would argue that they are necessary because you're seeing the earliest time points of fibrotic lung disease, and I want to see if this patient is going to progress. In addition, as we've talked about, this is an emerging field. We just started using the term ILA in 2018. And so now we're getting all of our thoracic radiologists on board to say, hey, this could be the earliest form of fibrotic lung disease. I'm going to dictate this as could represent interstitial lung abnormality should this patient get a follow-up. In addition, because ILA is so early on in the courses of fibrotic lung disease, it's unclear how great CT is at identifying for sure that this person has fibrotic lung disease. So newer technologies such as hyperpolarized xenon gas are being developed that may better assess pulmonary fibrosis in these earliest stages. Thank you all for joining me on this talk on interstitial lung abnormalities. This is an emerging topic that I think we all want to learn more about. I hope you found it to be educational. For more information on interstitial lung disease, please review Boehringer Ingelheim's websites, Insights in ILD, and IPF Radiology Rounds. In addition, please consider downloading the HRCT Focus smart device app called Rad Rounds from the App Store.